All right, so let's talk about hyper IgM syndrome. So here we have a 9-month-old boy brought to a pediatrician and got some recurrent respiratory infections, and we've got encapsulated bacteria and opportunistic pathogens with Pneumocystis jirovecii. And the family reveals that his maternal uncle died of severe infection. Lab studies show this: elevated M, hyper IgM, low everything else. And there's a deficiency of the CD40 ligand. They just literally tell us that. That's great. And so they're asking us which of the following immune components is most likely responsible. And indeed, it would be the CD40 ligand on the T cells that binds to the CD40 on the B cells. So let's talk about how this all works. If you have hyper IgM, it's an X-linked recessive disorder that's caused by that ligand deficiency. And the mutation causes the defective T cell mediated B cell activation. So you got to activate those B cells. And how do you activate them? Well, you activate them through the CD40L on the T cells binding to the CD40 on the B cells. And so that induces a germinal center formation, somatic hypermutation, and immunoglobulin class switching, which allows the M to switch over. And so if you don't have this, then you won't get, if you don't have that class switching, then you'll be stuck with only IgM. You won't have IgG or IgA or IgE. So that's the reason why this person has IgM. Let's look at the other ones. Complement protein binding to CD21 on B cells. So CD21 facilitates B cell activation by binding complement coded antigens. But in this case, we're talking about class switching, and that's defective in hyper IgM. So it's not the primary defect here. But B cell activation is important for complement by binding to the complement coded antigens. Antigen specific binding. So B cells do recognize antigens through the B cell receptors, and that does cause activation. But here we're talking about the class switching. And so the binding is unaffected. So it's all fine. Antigen binding is not the problem here. It's the class switching. CD18 to the ICAM. So CD18 is part of the integrins, which help the neutrophils adhere to the blood vessels. And if you have a deficiency, then it could lead to LAD, leukocyte adhesion deficiency, which presents with delayed umbilical cord separation, leukocytosis, and recurrent infections without pus. And it's not class switching related. So think of these with like these integrin formations, CD18. FC receptors, CD16, binding to IgG opsonized particles. So CD16 allows for macrophages and neutrophils to phagocytose, IgG opsonized pathogens. And here the IgG levels are low. And so there's reduced opsonization. So the CD16 is not directly impaired in this. Okay, so hopefully this is helpful. Basically, hyper IgM syndrome, you can't class switch because that activation through the T cells to activate those B cells so they can class switch is non-functional. And so you have a lot of infections with encapsulated bacteria and opportunistic pathogens that these other IgG, IgA, IgE kind of would have taken care of, but it doesn't because you can't class switch. Hopefully this is helpful, just a little introduction into some of these topics. If you liked it, then go ahead and like and subscribe.